So as all you know, patients with bicuspid valve, they were excluded from all randomized trials. So we don't have this top evidence to indicate TAVR in bicuspid valves. We have registry that shows good results, and there are several unclear points, including technique of annulus or supraannulus measurement, size of the ascending aorta, type of bicuspid valve, LVOT calcification, and others. Dr. Gada will present TAVR results, tips and tricks on bicuspid valves, and after his presentation, you can feel free to ask questions on the chat so we can discuss some practical points. I will keep all the microphones during his presentation off, so I will ask you to ask the question by the chat. So we have about 100 people online now and some waiting on the waiting room. And please, it's a pleasure for us to have you here, Hemal.
Thank you, Eduardo. It is really a strange time that we're living in now, but I really appreciate you inviting me to this great audience to talk about bicuspid transcatheter aortic valve replacement. And I'll talk about more of a contemporary, nuanced approach, not really delving into much old data, but definitely going into some new data, and then talking about maybe ways that we could employ cusp overlap to actually get better outcomes, even with bicuspid transcatheter aortic valve replacement. So I want to start off by just giving a general background of bicuspid aortic valve disease and the basics. This is a prevalent disease. It impacts about 0.5 to 2% of the global population. We can argue about whether or not there is such a thing as an acquired bicuspid aortic valve. This was a publication on the right there from 1973 that seemed to think that there was. More recent publications have dubbed all bicuspid aortic valves congenital, with some variation. There are genetic links. There are genes that have been tested that have been shown to be linked to acquiring a bicuspid aortic valve, obviously in utero. But in general, this is caused by the underdevelopment or malformation of the aortic root and resulting in only 2 functioning aortic valve leaflets. And the characteristics here include, obviously, abnormal cusp fusion, pronounced asymmetry of the valve orifice and annulus, heavily calcified and fibrotic leaflets, calcified raphe, and an enlarged descending aorta. The disease prevalence is quite high in younger populations. The older you get, the less likely you are to have bicuspid aortic valve disease. But this is basically, again, shown here. We're talking in the United States, somewhere between 0.5 to 2% of the general population, with most bicuspid aortic valves being found by an internist or a cardiologist somewhere between ages 50 and 80. Again, older than that, you're more likely going to see tricuspid aortic valve pathology. In the United States, approximately 1 in 5 patients over the age of 80 undergoing a surgical aortic valve replacement had a bicuspid aortic valve. So it's not like it doesn't exist. It's just higher in prevalence in younger populations. Not only is it higher in prevalence in younger populations, and there's a disparity in age, there clearly is a disparity in patients by country. Depending on the country that you reside, the prevalence of bicuspid aortic valve disease may be quite different. And in addition to that, the type of bicuspid aortic valve anatomy that you have may be remarkably different as well. This is just a nice little chart with regards to prevalence according to geography put together by a publication that's shown there. And really, we're talking about a range of somewhere between 1.5 to 7% in the United States and Western Europe. When we're talking about Asia, and then of course Latin America as well, those rates would be considerably higher, ranging well into the double digits in those particular regions. We use the SIEVERS classification to traditionally classify these bicuspid aortic valves to learn more about their anatomy and how we could endeavor to use a transcatheter heart valve prosthesis. In European populations, type 1 with a left and right coronary cusp fusion is the most common variant of a bicuspid valve. In an Asian population, your bicommissural non-RAF-A type morphology, aka type 0, would be more common. Shown here again, split for the United States, type 0 representing 7%, type 1, 88%, type 2, 5%, and then showing what exactly that consists of or looks like anatomically. On the left side there, type 0, 2 normally developed cusps and commissures, there is no third, and there is no RAF-A. Type 1, about 88% of patients, your left-right fusion is going to be the most common, and you usually have one full or partial RAF-A as a result of the patient having a type 1 bicuspid valve. Type 2 bicuspid valves, you're talking about 2 full or partial RAF-As, and these are very uncommon, the most uncommon form of bicuspid pathology. The disease progression, well, it is latent. So if we assume that most, if not all, bicuspid aortic valves are congenital, although present at birth, individuals with bicuspid aortic valve disease are typically asymptomatic until later in life, but it's not that much later in life, obviously relative to the tricuspid valve disease patients, and it is aggressive relative to those tricuspid patients. And so here you have a development of a valvular sclerosis in the bicuspid valve that generally begins in the second decade of life and then progresses more than what we would expect in tri-leaflet patients. Over half of bicuspid aortic valve patients develop valvular calcification that can progress to severe aortic stenosis in as little as 10 to 12 years. In contrast, you're talking about a minority of patients with tri-leaflet valvular calcification that would then progress to severe aortic stenosis. It is a muddy etiology. We're talking about genetic and mechanical components that are likely contributory, some of which are dependent on one another. But a couple of hypotheses here: a valve and ascending aortic tissue in these patients may be more susceptible to calcification. And then you may get eccentric jets from the asymmetrical bicuspid aortic valve leaflets that may increase wall shear stress, inflammatory factors that would then lead to the formation of calcification on these leaflets and dilation of the ascending aorta. So you have these anatomic considerations. You have heterogeneous cusp and sinus morphologies, heavy and asymmetric calcifications, and long commissural distances, which may pose a challenge for all transcatheter heart valve platforms. In addition to that, you have aortic root angulation, the horizontal aorta or the vertical annulus, aortopathy, and then of course aortic coarctation, which is present in a variable percentage of these patients. So this does introduce potential challenges with regards to transcatheter heart valves, as kind of delineated on this table based on the anatomic feature. So the anatomic feature of an elliptical annulus, well, your potential procedural concern here is impairment of positioning and sealing. Asymmetric leaflets and or asymmetric leaflet calcification that could impede or impair valve expansion, leading to augmented gradients or paravalvular leak. Fused commissures or RAF-A, you have a risk of potentially aortic root rupture during balloon valvuloplasty or valve deployment itself. And then finally, aortopathy, which may obviously risk aortic dissection. If the aortopathy is significant enough, those patients may be taken off of a list to consider them for transcatheter heart valves because they essentially have two problems. And of course, difficulty anchoring of some transcatheter heart valve platforms. So I did want to present some selected outcomes data, more recent. I'm not going to rehash a lot of the work that's been done in this field with high and intermediate risk patients, but I did want to focus on a contemporary TVT registry analysis that was done with SAPIEN 3. I wanted to focus on a TVT registry analysis that was done with the EVOLUT, and then I wanted to gloss over the EVOLUT low-risk bicuspid study that was presented virtually at ACC this year. So I will start with this great study that was presented in ACC 2019. This is now published. This is an analysis of the STS and ACC TVT registry for SAPIEN 3. This is basically what it consisted of, and it was one-to-one propensity matching between over 2,500 bicuspid aortic stenosis patients and 79,000 plus tricuspid AS patients, and whittling that population down, not so much on the bicuspid side, but obviously on the tricuspid side, to create pairs. And these pairs did end up being clinically similar we're talking about an STS score on average of roughly 5%, with a significant standard deviation around that. You can see the comorbidities more reflective of an intermediate risk population, in contemporary management. But this is really what the propensity matching revealed. The other thing about this was obviously the discrepancies anatomically between these bicuspid and tricuspid aortic stenosis patients. In general, the bicuspid aortic stenosis patients received larger valve sizes than tricuspid AS patients did, as shown here. And these were significantly different between these two groups. When we look at complications, the complication rate was somewhat higher with bicuspid AS patients. The conversion to open surgery, annular rupture, these were significantly different between the two groups. And then the need for a second valve was not significantly different between the two groups, but is highlighted in this presentation. All stroke was a significant difference favoring tricuspid AS with regards to treatment with the SAPIEN 3 transcatheter heart valve prosthesis. And the pacemaker rate was also significantly higher in bicuspid aortic stenosis patients. Now, we're going to see this happen over and over again with the data that I show you. We're going to see that pacemakers tend to be higher with the implantation strategies of these valve prostheses in bicuspid AS patients. And by the end of the presentation, I hope to show you a little bit more of a nuanced way of maybe deploying these valves that would lead to less conduction disturbance. So this was the primary outcome, basically. Just look at one of the primary endpoints that matched one-year mortality, very similar between the two groups, not statistically significantly different at 1 year. 1 year stroke, low rate across the board, matched here between bicuspid and tricuspid aortic stenosis, no significant difference there. Mortality or stroke matched, again, no significant difference. When we look at paravalvular leak, the SAPIEN platform does very well with PVL outcomes. Looking at none, trace, and mild paravalvular leak, we don't see much in the way of difference between tricuspid and bicuspid patients. The hemodynamics are well into the double digits with regards to both tricuspid and bicuspid AS patients in the TVT registry, as shown here. The numeric values aren't presented, but it's a little bit greater than 11 millimeters mercury across the board for the bicuspid and tricuspid patients, corresponding to that aortic valve area, which is, again, not significantly different between the two groups. When we then fast forward to the EVOLUT R versus PRO analysis in the TVT registry, you're going to see a lot of things that are going to be particular to each valve platform basically emphasized here. But as you know, EVOLUT R and EVOLUT PRO represents a generational difference with regards to self-expanding prosthesis. The EVOLUT PRO has a pericardial wrap around the base of the valve, enhancing paravalvular leak outcomes. And so when we look at the TVT registry, again, differentiating between these two devices, we can see that there's really not going to be any significant difference with regards to EVOLUT R versus EVOLUT PRO in this analysis. Now, the tricuspid versus bicuspid patients, of course, there's a difference. The bicuspid patients end up being younger. They end up having a lower STS score. But as far as procedural outcomes are concerned, you'll see here that between tricuspid and bicuspid patients, there wasn't anything significant that popped out in this analysis. With EVOLUT R, there tended to be a greater rate of moderate or greater paravalvular regurgitation in the bicuspid AS group. But with EVOLUT PRO, you'll see that that's gone, and it's likely because of that pericardial wrap around the base of the valve. Pacemaker rates remain high. And so if we look at the EVOLUT R platform, over 15% pacemaker rate with tricuspid and bicuspid aortic valves with EVOLUT R. With EVOLUT PRO, pacemaker rates well into the double digits. We'll then talk about the low-risk bicuspid study that was just presented at ACC 2020 virtually by my good friend Basil Ramlawi. The valves studied here were the EVOLUT R valve, 43%, 57% received the EVOLUT PRO valve. The Pro Plus platform was not available at the time of the low-risk bicuspid study. In full disclosure, we were the 6th highest enroller in this particular study. The key exclusion criteria are listed here, including significant aortopathy, prohibitive left ventricular outflow tract calcification, Really, that's about 4 millimeters in and 10 millimeters down from the annular plane. And then anatomic dimensions that are outside the recommended range. Here, a sinus of Valsalva of greater than or equal to 25 millimeters as well. And the annular range that we're talking about is 18 to 30 millimeters. The patient flow is shown here. 222 patients were screened. It ended up with 149 patients that received an implanted transcatheter heart valve with 1 conversion to surgery and 1 death prior to 30-day follow-up. When we look at the patients that were excluded for anatomic reasons, we see that really there was not much exclusion for, say, prohibitive LVOT calcium. That was really not factored in any impactful way with regards to exclusion criteria. There were some patients who ended up having a tricuspid aortic valve that were reviewed by the screening committee and tossed out specifically because of that reason. Baseline clinical characteristics are shown here. Clinical characteristics are reflective of a low-risk population. Your average STS score was less than 1.5. The AS was obviously very real with a mean gradient of 48 millimeters mercury. This shows the divisions between the various subtypes of bicuspid aortic valve. Type 0 really only represented 14 patients in this particular study. The vast majority of patients were type 1, SIEVERS type 1 patients. None of the patients in this study had a SIEVERS type 2 bicuspid aortic valve. The procedural characteristics are shown here. Again, lion's share majority of patients got larger valve sizes. There were no 23 millimeter prostheses implanted in this study. Most of the patients got 29 or 34 millimeter prostheses. Predilation, while not required in this study, was heavily recommended, and we uniformly did it on all of our cases aggressively. So depending on the operator, the balloon sizes were a little obviously different between sites, but over 90% of the patient population received predilation. And you can see here again, a large percentage of the patients received the CoreValve XL. When we look at 30-day all-cause mortality or disabling stroke in this trial, we have an endpoint of 1.3%, or a primary endpoint achieved to 1.3% at 30 days of death or disabling stroke. The other outcomes at 30 days are shown here. Again, permanent pacemaker implantation remains a problem, well into the double digits with regards to this particular study at 30 days. Additional outcomes at 30 days, device success was quite high. The rate of patient prosthesis mismatch as conventionally defined was quite low, with almost no patients having a mean gradient of greater than 20 millimeters mercury at the end. And again, the hemodynamics kind of play into these various platforms. With EVOLUT, we would expect to have lower echo-based gradients, and that is really what this trial showed. Interestingly enough, there was no significant difference between type 0 and type 1 bicuspid aortic valves with regards to the hemodynamic profiles. When we look at total aortic valve regurgitation at 30 days, type 0 patients, and albeit it was a small number in this study, tended to have less paravalvular leak than the type 1, SIEVERS type 1 patients, which had a healthy minority of patients that had mild paravalvular leak. There were no patients in this study that had moderate or severe levels of paravalvular leak. So then the first question I would ask everyone is, how do we then go about sizing these valves? And Eduardo actually had a very nice preface to this with regards to annular versus supraannular sizing. And so let's talk about that. Well, there are 3 basic ways of sizing these valves. You have an annular plane that you could use, and to reconstruct that may be a challenge, and we're going to go over that. You may want to do supraannular sizing. So knowing that the seal of the bicuspid valve with a TAVR is going to happen higher up, somewhere in the range of 4 to 6 millimeters above the annular plane, you would then move to perhaps supraannular size. And there are a couple of different ways of doing that. You could do an intracommissural distance as shown here, or you could create this arbitrary shape and develop a perimeter there and assume the bicuspid valve is going to morph into that at the seal zone and base your decision-making on that. The other thing that you could do interprocedurally perhaps is balloon size. But all of these, a couple of these things definitely have some issues involved. So is validity or reliability of these techniques an issue? Well, this is us doing a procedure where we used a very small 18-millimeter balloon to prove a point. Doing an aortogram at the same time, this patient did not end up getting a small valve prosthesis. They sized for quite a large one. But you can see here, just by blowing up an 18-millimeter balloon, you can eliminate all aortic insufficiency. So this is not a reliable way, I think, of sizing a transcatheter heart valve prosthesis. Similarly, a transcatheter heart valve may circularize a little bit more than we give it credit to do. And so on the left there is that previous reconstruction that I showed you with kind of an imputed way of assessing how a valve would meld to the anatomy, but then seeing how the valve was actually deployed and looking at a CT afterwards, you can see that the reality is quite different. So this was a really great study, an article that was published by my good friend Didier Cheche, the Bavard Multi-Center Registry, looking at a bunch of different things, but assessing really intracommissural distance versus more of an annular sizing approach. And I think developed a little bit more information with regards to the anatomies that we should be using each of these sizing mechanisms for. And so this is really the posited schema, which we use actually pretty readily. The intracommissural distance is obviously up top in the sinuses, and then you have the aortic valve annulus, and there's roughly, again, a 4 to 6 millimeter difference. Nico Piazza thinks that the seal zone is 5.7 millimeters above the annular plane generally, and that's where we typically measure our intracommissural distance and try to get a gauge of what supraannular sizing would be. But as you can see on the schema here, that in this particular study, about 90% of the patients had the sizing that was based on the annulus. And really the only patients where you're thinking about intracommissural distance is when you have a tapering up top and a wider annulus on the bottom. And a lot of that is, again, because the seal zone is higher up, you can use the smaller of the two. And really that's the critical piece of this, that you can actually be less oversized with these valve platforms, and that could paradoxically lead to not only less conduction disturbances, which is not paradoxical at all, but also better hemodynamic performance. And so looking here at this ellipticity measurement, looking at what happens with a tube versus a flare component, you're looking at valve sizing that really respects these prosthesis to annulus ratios as defined in the article versus more of a taper, then you're really downsizing these valves to fit anatomies that don't need to have tremendously oversized transcatheter heart valve prostheses. So let's just go over then a routine deployment. We've sized our valve. In this particular case, we're going to pick a 26 millimeter Sapien 3. And then this is what an aortogram could look like. And so you could have, here is a Sievers type 0 valve. You could put a pigtail in the anterior cusp, a pigtail in the posterior cusp, and you could find some coplanar view and inject dye accordingly, and really just find any permutation of what could exist as a coplanar view and deploy accordingly. Now, keep in mind that there are some native anatomic features that you may not have respect for when you do this, and we're going to talk about that in a moment. Here, we're going to do a pre-dilation with a 20 millimeter Edwards balloon. And then here, we're going to deploy our valve, kind of textbook teaching. We're going to keep that middle marker just above the base of the pigtail in this particular view, and then we'll go ahead and deploy. And after deployment, we see some paravalvular leak. So we'll go right back in with the balloon, add a couple cc's to it, and then we'll flare out the valve. And we get a good outcome. So now we have no leak, and hemodynamics here were pretty good. We had a mean gradient of about 12 at the end of the procedure. And so when we think about how deep we've deployed this valve, depending on the aortogram, you can make yourself think that you deployed right in the annular plane, or you can shift the aortogram and make yourself think that you deployed deeper. And if we look at the transthoracic echo, especially this apical 5-chamber view, we can see that we clearly deployed this valve below the annular plane, maybe deeper than we needed to deploy it. And so the skirt of the Sapien 3, which is designed to enhance paravalvular leak reduction, really is deployed with a large part of it in the left ventricular outflow tract where it does not need to be. So is there a better way? And I would argue, yes, there is. If we know the conduction system, and the conduction system as it exists for trileaflet valves exists for bicuspid valves, we should be able to parse together a better strategy for valve deployment. And so really what that comes down to is this anatomic map. The non-right commissure as it exists in tri-leaflet tricuspid valves, below that is a membranous septum, below that is a muscular septum. That is really the hallmark of electrical conduction as it exists below the AV node. And so understanding the non-right commissure is the absolute key to avoiding conduction disturbances during any transcatheter heart valve implantation. And so this is just a simple experiment of where did it land with a SAPIEN. We have non-right left equidistant coplanar across the screen. We're going to go ahead and deploy the SAPIEN valve using LV pacing like we typically do. Once it is fully inflated, what we're going to get is this parallax, right? Parallax on the platform. And we see this not just with tricuspid valves, but with bicuspid valves as well if we don't understand the anatomy. And so here, what we've done is we've deployed a valve in a way where, yes, we've created this traditional coplanar view, but now we're trying to understand where exactly did we deploy the valve? Is it 2 millimeters below the annular plane? Did we barely catch the annular plane? Is it 6 or 8 millimeters below the annular plane? And so this is where this whole concept of cusp overlap comes into play. But the first thing I'm going to do is I'm going to reconstruct the bicuspid annulus for you, SIEVERS 0, to show you how I like to reconstruct aortic valve planes. Now, on the right here in 3 Mensa, you'll see that there's an option for a 2 cusp, but keep in mind that an annular plane has to have 3 dots. A line is made of 2 dots, a plane is made of 3 or more. And so here, what we're trying to do is create an artificial division in that posterior cusp such that we are respecting the what would be the non-right commissure, what is going to be the membranous septum, and what's going to be then the muscular septum below that. And so the implantation gantry view that we're going to achieve is largely based on, again, respect for where the membranous and muscular septum are, which we believe would be in the non-right quote-unquote commissure. And of course, the non and right coronary cusp do not exist in this patient, but anatomically, the conduction system should not be far off from where we would predict it to be. So after kind of monitoring these dots and creating the annular plane, what we're then going to do is go to our measurements. And so in this particular patient, we've measured a perimeter of, I'm sorry, let me just go back to that and fast forward. So when we do our annular reconstruction, we're going to go ahead and just measure this patient. This patient's going to have a perimeter of about 69 millimeters. This patient actually ended up getting a 26 millimeter EVOLUT Pro valve in the Medtronic low risk registry. And so here we're going to then go to cusp overlap, which is, again, overlapping the right and left coronary dots, keeping in mind, obviously, that this patient is a SIEVERS 0 bicuspid. So really what we're defining is that membranous septum and the muscular septum coursing in between these 2 dots. And if we can set up a fluoroscopic image like that, we're going to deploy in reference to the conduction system, and we can have shallower deployments as a result of doing that. As you can see here, we can do some superannular sizing. I'm going to go up to 5.7 millimeters above the assessed valve plane here. And then I'm going to draw largely arbitrary structures. So here we're going to use the ellipse tool, and I'm going to draw where I think the valve is going to land and what it's going to look like. And again, this is very difficult to do. I think that the intracommissural distance is probably a better way of assessing superannular metrics if you're interested in that. Again, this particular patient went on to receive a 26 millimeter EVOLUT prosthesis. So what we're talking about is just using 2 views. We're going to start out in a view that overlaps the right and left, leaving the non-independent. Depending on your SIEVERS anatomy, you may still be able to do this. SIEVERS 1, SIEVERS 2 valves, you should be able to really reconstruct the annulus just like you would in a tri-leaflet tricuspid valve. We're trying to visualize here the non-right commissure, or where it would be, because that's where we believe the membranous septum and muscular septum are in these patient anatomies. It's most often an REO or AP caudal view that you're going to define as being the optimal projection. And that view will also take parallax out of the ring of delivery catheter of the EVOLUT, leading to more simplicity with regards to that particular prosthesis deployment. For the self-expanding valve, and this is not necessary for the balloon expandable, but for the self-expanding, after flaring out and understanding depth related to the non-coronary cusp or the posterior cusp, we then rotate LAO to take parallax out of the valve frame. And here we ignore depth relative to everything but essentially the left coronary anatomy. So I have an example case to show you. This is a 71-year-old gentleman with coronary artery disease, type 2 diabetes, stage 3 chronic kidney disease. He's had multiple heart failure presentations. His STS predicted risk of mortality was 1.9% for surgical aortic valve replacement, essentially a low-risk patient. He actually came to us from Pakistan. My surgeon that I work with most often, Dr. Mubashir Mumtaz, he hails from Pakistan, and so this was just a friend of a friend. He was offered surgery in Pakistan and came to the United States for transcatheter aortic valve replacement. We deemed him low surgical risk. We availed him of all of his options, including various modalities of surgical aortic valve replacement, but he was really adamant about transcatheter aortic valve replacement. And of course, you know, we're always concerned about CMS in the United States, but this patient was self-pay. And so here we have a mean gradient of 50 millimeters of mercury. We could see on the moving images here for the transthoracic echo, your peristernal long axis and apical 5-chamber views showing a heavily calcified stenotic aortic valve with trivial to mild paravalvular, aortic valve regurgitation. Your CTA reconstruction, so we had a perimeter of 81.9 millimeters, where if we look for the instructions for use for an EVOLUT platform, you're right on the border here. So we could have done a 26 millimeter SAPIEN 3. We elected to move forward with a 29 millimeter EVOLUT Pro in this anatomy. And we could talk about, again, the sizing considerations here. Would you size up? Would you size down? When you see the sinuses, I think you'll get a reason why we ended up sizing down in this particular patient. And so this was the annular plane as we reconstructed it. The left ventricular outflow tract was basically a cylinder down from the annulus. In the sinuses, we saw an intracommissural distance that was pretty robust, but we see a SIEVERS 0 bicuspid valve with a heavily calcified anterior left leaflet. And so this gave us pause to think again about how we're going to get this guy his most optimal hemodynamic outcomes, not have a significant increase in our risk of conduction disturbance, have more control over valve deployment, and yes, get the best hemodynamic outcomes. Here we look at the sinotubular junction as well, just in case we have a pop out. We need to understand what that effect would be of putting in a second valve. Ascending aorta, looking at aortopathy, and again, some of these second valve issues, always important to look at that supraannular anatomy. Left main height looked good, 17 millimeters. The sinus of Valsalva was quite high up. The right coronary height looked good at about 19 millimeters. So again, the reconstruction here is largely, I would say, an exercise in some imaginative thinking. We're trying to divide out two of the leaflets and create, again, a heuristic that respects the membranous and muscular septum as it would course down in what would be the traditional non-right commissure. And so here is the traditional quote-unquote coplanar view that we have here, LAO 8, cranial 9. As we migrate down the S-curve to overlap those two dots, the red and the green, we have an REO 26, caudal 29 angulation that we use for the deployment. We calcium score based on Hounsfield unit of pacification in the blood pool. We use a tool on 3Mensio called Pixel Probe that allows us to assess the amount of calcium. In these bicuspid valves, like I said, uniformly, we're pre-dilating, and we're pre-dilating pretty aggressively in these patients. So our plan was right transfemoral access. The transfemoral access was not an issue in this patient. 29 millimeter EVOLUT Pro platform with a 25 millimeter true balloon pre-dilation. We used left ventricular wire pacing, and we put in sentinel cerebral protection systems in virtually all of our cases that are anatomically eligible at our center. You see here the initial aortogram, again, isolating that posterior cusp, creating a heuristic that allows us to really visualize that membranous septum in the center of our screen, allowing us with confidence to implant shallower and avoid conduction disturbances. We start with the EVOLUT platform with the marker band here located pretty much at mid-pigtail. We have a double curved Lunderquist wire in the ventricle, which I agree is not the best placed wire, but we're going to fix that. As you see right there, we just pull it back and then just gently re-advance the wire. When we get up to about the third node of our EVOLUT deployment, we like to rapid pace. Here, we're going to rapid pace at a rate of 180 beats per minute. And this is kind of, again, a separate topic as to how we actually complete these deployments. But the point here is to just look at where we're actually deploying the valve. And so here, the seal zone we know is going to be higher up than the annulus. So we can afford a shallower deployment. We don't even need a 2 to 3 millimeter depth of deployment. If we get a 0 or a 1 in these particular cases, I'm perfectly happy because we're likely going to have an optimal outcome with regards to hemodynamics as well as PVL, especially given the wrap around the base of that EVOLUT Pro valve really shutting down any small jets. Then we rotate the gantry LAO to see that our left coronary really looks nice, well perfused there. And you can see how shallow the valve looks on the non-coronary side. This is just because of the aortogram that we're taking and the particular view that we're taking it in. So understanding the anatomy is obviously very important in these particular cases. When we do an aortogram at the end, we're going to do it in an original cusp overlap view, and you can kind of see the outcome there. Nice high deployment, no conduction disturbances at the end. You can see kind of what we're left with hemodynamically, a mean gradient of 4 on transthoracic echo. And you can see again that we've had a nice high deployment with no jets of paravalvular leak. EKG afterwards looked great. You could do this with SAPIEN as well. And so here we have a cusp overlap SAPIEN case, non-isolated. We like to place the middle marker around mid-pigtail on that posterior cusp. And when we deploy that valve, you can see that radiolucent line. We like to keep that just at the lower part of the pigtail. The beautiful thing about this particular deployment, as you'll see with non-right commissural wire placement in this view, is that you very rarely get any significant parallax in the SAPIEN as well. And so you actually can ascertain your deployment depth as it would relate to the conduction system. So for discussion and things that I want to hear Eduardo opine about a little bit, in addition to answering some of your comments and questions, I think that outcomes appear to significantly be significantly improving with newer generation TAVR devices, and could get better with more nuanced procedural planning, as I've kind of shown you today. So Eduardo, is there a role for randomized controlled trials still, bicuspid TAVR versus SAVR, and how would we go about doing something like that, especially now that we have low risk studies that are coming out? And device selection issues, what anatomy for what valve? I think that we all have our personal preferences, and we all have our personal preferences based on individual anatomy, and we all try to take idiosyncratic approaches to our patients. And so I would ask everyone to kind of think about what procedural and clinical outcomes are the most important to you and how you assess your patients and the valve choice. So that's the end of really the presentation, Eduardo, and I wanted to kind of hear your comments on that first bullet point, and then we could talk about some of the comments and questions that have been raised by the audience.
Thank you very much, Hemal. Excellent presentation. We have, as you are very famous, we had almost 150 people watching your presentation. So
famous or infamous, Eduardo?
So we have some questions here. The first one is from Milton Santoro from Santa Catarina and Tocantins, asking if the previous repair of an ascending aorta aneurysm carries any additional worries to implant a TAVI, or there is no problem of previous ascending replacement.
I've not had any issues with that particular anatomy. Now, I will say that aortopathy in general gives us pause because we know that at least there's a risk of aortic dissection later after TAVR implantation. We've seen that, and that's been published in the literature. But as far as previous, aortopathy repairs, that does not give me much pause. Obviously, I want to understand the anatomy a little bit better. I want to understand what the valve is going to be anchoring to, especially if it's a supraannular prosthesis, what type of constraint I could have above the level of the sinus of Valsalva in some of these repairs. So all of that is important information to take in, but just based on someone's repair, that would not give me pause.
Okay, and Gustavo Judas from São Paulo is asking, how about you deal with low coronary ostium and bicuspid valve? And I would add, when do you contraindicate and when do you protect coronaries and bicuspid valves?
It's a great question, and I think that that's also valve dependent. Obviously, with coronary heights, as far as perfusing them and getting the patient through the procedure, supraannular prosthesis really is a great tool for that particular type of anatomy, because there you're not getting maybe the pinning back of the leaflets that you would get with, say, a balloon expandable or a mechanically expanding platform. And so in those particular cases, I would tend to favor self-expanding prostheses. I don't think that any valve is necessarily contraindicated at this point. We've not done any bisilica cases, but there are definitely operators out there that have done that and have had a good amount of success with regards to basically creating 3 leaflets out of 2, using electrical cautery type of systems that would be employed in a basilica procedure. All of those things are possible. They're totally off label and things that, we wouldn't promote in the context of normal practice. But they're things that people are doing out there. I think more commonly people are wire and stent protecting these low coronaries. And so here I would say something around 10 millimeters coronary height, again, depending on the sinus width, depending on how bulky calcified the leaflet is, would give me pause with a balloon expandable platform. Would I have to snorkel stent, stent protect a left main? I think that would probably be my general cutoff with those particular valves.
Okay. Ana Paula, who did her training here with us in Porto Alegre and is now in Zurich with Maizano, is asking if you use the cusp overlap also with the sapien implantation. I think you have addressed the advantage of using this projection as well with the balloon expandable valve, correct?
Yeah, I think so, Eduardo. And I think that most of the time with balloon expandable, the great thing about that valve is that, it's fairly forgiving. Like you can be off a couple of millimeters and not even know it. And, you're probably going to get a higher depth of implantation than say with an EVOLUT where you really have to understand the anatomy a little bit more. You just can't pick an arbitrary gantry angle and think that you're deploying at some depth. And so the room for error is different between the 2 platforms, but I appreciate the clarity that cusp overlap gives me regardless of the valve platform that I'm using.
Okay, there are many people saying amazing presentation, excellent Hemal. So I agree with everybody who's.
Eduardo, can you talk about that a little bit though? Can you talk about that top bullet a little bit? Just I wanted to hear you're a polished surgeon. You've been doing this for a long period of time. All of a sudden, TAVRs are walking into your market for bicuspid AS without even a randomized controlled trial. I wanted to hear you talk about that a little bit.
Yeah, I think we have some evidence from the studies from the registry you showed, and from this study, the prospective non-randomized study that was presented now at ACC, that give us some clues to use TAVR on bicuspid valves. But I think that the final answer will be with a randomized trial, because I think there are several types of bicuspid valves, and there was some exclusion criteria in this study. And I think that the study still has to go on, because it's just a 30-day result. And if you compare, for example, the rate of pacemaker in this study, it was, I think, almost 15%, correct, if I'm not wrong.
Yeah.
Yep. So I think we should try to learn with you how to lower this pacemaker rate and have a longer follow-up, because we noticed that almost 40% of the patients had a mild aortic regurgitation. And I think that with surgery, we can have better results in most of the patients with bicuspid valves. And as you said, most of the patients was SIEVERS type 1. And there was just few patients SIEVERS type 0 and no patients SIEVERS type 2. So I think the anatomical characteristics of bicuspid valve is very important when you plan TAVR and decide between TAVR and surgery. What do you think about the possibility of doing randomized trials?
I'm in favor of it. I think that there are just too many unknowns in this particular field, bicuspid TAVR in general. I think that if we're going to be scientific about it, like we have with all things TAVR, I think that we should be doing randomized controlled trials, especially in this arena where you talked about that there's a little bit of variability, and that the outcomes with regards to the TAVR platforms have not been, surgical level, if you will. I think that it definitely behooves us to think in that direction. How that gets constructed and what company is willing to come to bat for that sort of thing, I don't know how that's going to happen. But I agree, it's an academic endeavor that should be done.
Paulo Schwartzman, who is a radiologist here in Porto Alegre, and Rui Almeida, our past president of the Brazilian Society of Cardiovascular Surgery, they are asking almost the same question, that how can you predict the orifice that the valve will conform in the bicuspid valve, as you showed in the supraannular measurement? I think there's no magic answer, but
there's no magic answer. And I hate seeing pictures like that, but I put them up anyway. But I think it's largely a figment of people's imaginations. You know, like when I got my 8-year-old and myself, like tracing what it's going to look like supraannularly, I think that we're both probably have the equal chance of being correct. So, I mean, as that one slide showed you, I mean, depending on how the valve conforms, what kind of cant you have, you can be more circular than you think you're going to be, even with the self-expanding prosthesis at the seal zone. So no, I agree. I think that the supraannular measurement, as far as perimeter sizing is concerned, I don't find that to be a reliable or valid method.
Okay, I have unlocked all the microphones. So if any one of you would like to ask a direct question to Hemal Gada, please feel free to unlock your own microphone so you can ask a direct question to Hemal. But when you think about the question, I would like to ask you, in your practice, I know you do almost all the cases with minimally invasive procedure, local anesthesia. Do you think there is a role in some cases for TE, in these cases, to evaluate better the result of the?
But it's a great point. And I think that when we weren't as familiar with the anatomy as we are now with regards to imaging, I think that we have a very low threshold for putting a TE probe down to assess not only the result, but where we're deploying the valve. Because I think that especially with a SIEVERS 0, you have a lot of confusion where you're exactly deploying the prosthesis. So now that we understand it better, I think we're able to get by, you know, more without TE. And then now, you know, even with the self-expanding platform, having the wrap around it, we're less concerned about paravalvular leak rates. So that really has not been a significant issue with bicuspid TAVR. But yeah, there's some anatomic instances where I think it provides a lot of useful information.
Any question directly to Dr. Hemal?
Eduardo, I have a question.
Yes.
Can you hear me?
Yeah, we can hear you.
First of all, I'd like to thank Dr. Hemal for the excellent presentation. And I'd like to ask, which criteria Dr. Hemal used to predilate a bicuspid valve?
Yeah, it's a great question. And like I said, I pretty much uniformly predilate all bicuspid valves. So it's not like what criteria, because I'll just go and do it. It's what balloon size do we typically end up using. Now, we like to be aggressive. And the aggressiveness of the predilation, especially in SIEVERS 1, is not to crack open some raphe. It's to mobilize the non-fused cusp such that the valve has a place to reside and expand into, so that it's not underexpanded or constrained. And that especially is pertinent with the self-expanding prosthesis. So I would say that we're aggressive to the point where we're measuring the annular plane, we're measuring the left ventricular outflow tract, and we're seeing what the lesser of the two means are. If there are worrisome features in the LVOT, we'll probably go by the minimum diameter. But typically, we're going with our mean diameter of whatever is less between the annulus and the LVOT, and we're predilating based on that. Now, we've had a couple of instances where we've had significant aortic insufficiency after the predilation. If you have the access for it, I would have your standard sheath in where you don't need to do a sheath exchange for any device or anything like that. Go in with the balloon, do your predilation, come out with the balloon, and through the same sheath, if you've got the access for it, go right in with your delivery catheter and valve delivery system. So I think that, you know, you have to be sensitive to that you may have some varying degrees of aortic insufficiency, but we're not talking about a long period of time, you know, between your balloon valvuloplasty and then the transcatheter heart valve deployment. So again, we're very aggressive on the predilation just so that we get that type of apposition and expansion that we want out of our valve.
Dr. Kubrusli, how are things in Curitiba?
It's getting cold right now.
Yeah.
Yeah, very nice presentation. Congratulations for you and for your talk. It was very good.
Thanks, Luis.
Thanks. Any other question? So I'd like to thank everybody for participating in this meeting. Thanks, Dr. Hemal Gada, for excellent presentation. He's always available, a very good friend of us, and a very skillful operator. So stay safe, everybody, and have a good night. Thank you very much for all.
Thank you. Good night.
Okay, congratulations.